Hello, and welcome to Chapter 4. Today we're going to talk about assessing preventive measures, and specifically we're going to talk about randomized trials. First of all, let's go over the two main types of study designs in epidemiology. The two main broad categories are non-observational studies, such as experimental or randomized trials, and quasi-experiments. The second type is observational studies, which are quite common in public health. Observational studies include cohort, case control, cross-sectional, and ecologic studies. We will discuss all those in detail. Do you think controlled trials are a new type of study design? No, not really. Back in 1747, James Lind ran a planned controlled trial to figure out what was causing scurvy. Scurvy killed thousands of British seamen each year, and Dr. James Lind was asked to identify the cause. He decided to run 6 different experimental groups. One would be on a cider diet, one in seawater, one in vinegar, one in citrus, one in a nutmeg diet, and one in vitriol. I would not think that one in the vitriol diet did very well at all. Anyhow, after a few days, the sailors following the citrus diets were cured of the disease, and the ones in the cider and vinegar show a mild improvement. Hence, lemon juice became a required part of the standard diet of British seamen. Scurvy disappeared from British sailors. In this figure, you can see the difference between experimental or randomized studies and observational or non-experimental studies. So they both start with a certain population of interest in mind, but as you can see, the main difference is that the experimental design, we randomly allocate participants to either an exposed or not exposed group. Think of a drug evaluation trial. On an observational study, on the other hand, we do not randomly assign participants into group. They fall naturally to them, if you may, simply because a lot of times it is unethical to assign people on certain exposures. For example, you may have a group of smokers and non-smokers, and you may choose to follow them over time. You cannot take people who do not smoke and randomly assign them to a smoking group. As you can imagine, different types of study designs present different challenges, and a good researcher needs to be aware of all those challenges in order to compensate by taking all the appropriate measures. So, when do we use randomized trials? We use them for many purposes, but pharmaceutical companies use them very often to test the efficacy of new drugs. Also, any time there is a new treatment, whether it is a surgical procedure or implementation of a new screening program, we would want to see if the new treatment works better than what is currently being used in order to eventually replace it. Randomized trials can also be carried out in the community. For example, testing whether a particular delivery of health services system works better. Hence, we call them randomized trials, although in clinical settings it is mostly known as RCTs or randomized control trials. The link highlighted on the slide, it is from the U.S. Food and Drug Administration website that explains clinical trials in detail and also provides an opportunity to participate in any RCT available. We always begin with a clearly defined population that is randomly assigned to receive either new treatment or the current treatment. We follow the subjects in each group and we try to see how many have improved with a new treatment and how many improved with the existing treatment. If the number of people in the new treatment that have improved is significantly higher than the existing therapy group, that means that the new treatment is working better. Sometimes, researchers may choose to compare multiple groups or compare groups with a treatment and one without a treatment at all. What does it mean to randomize, and why do we randomize? Going back to your statistics class, to randomize means that everyone in the population of interest has an equal chance of being selected. Randomization is the best approach in the design of a trial. Not knowing where the next assignment will be is the key element and benefit of randomization. Predictability of the next assignment would be the greatest design flaw for such design, in order for the findings to be meaningful. How do we randomize? There are several ways to randomize participants into groups. One is using random number tables, which are usually found in the back of statistics books, or they can be generated by computers. Today, we mostly use computers, especially for large trials. How do we use a random numbers tables? Pretty easy. Let's just say we have two groups, A and B. We can create an algorithm for assigning people to one of those groups. It can be done by either choosing every odd number to be in group A and every even number to be included in group B. Or we can even decide persons from 0 to 4, so every 4 numbers people move to either A or B groups. This would be more like a systematic random assignment. Here's a table with random numbers. We can have every even number join group A and every odd number join group B. We can even close our eyes and point to a number. We can then identify the location of that number by specifying the row and column of that particular number. It is important to do so in case our randomization process needs to be checked by an outsider. Why randomize? What is the big deal? Well, we need to ensure that we minimize any subjective bias by investigators that may influence the process of selecting patients to a group over another. For example, it wouldn't be fair if researchers who invested years of hard work to be allowed to select participants, since there's a possibility that may place persons in a group that would essentially enhance their findings. Maybe the participants are in better health or more likely to comply. Whatever it may be, the idea is that the two groups that we are comparing should only differ in the treatment that are getting and not in anything else. If they do differ on other characteristics, then how do we know that the treatment is working and not those other characteristics do not play a role in influencing our findings? Characteristics such as sex, age, severity of disease can greatly influence findings. Thus, in order for the two groups to be comparable, they need to be similar as possible by eliminating all biases. To reiterate, the main goal of random assignment is to prevent any potential biases on the part of the investigators from influencing consciously or unconsciously the assignment of participants to different treatment groups. One thing that you need to remember is that although random assignment increases the degree to which our groups are comparable, it does not guarantee comparability. Therefore, comparability of the treatment groups, it is not the main purpose of randomization. On this figure that shows you patients with and without arrhythmia, I want you to pay attention to the differences in the assignment of the groups between observational and experimental study group. Non-randomized studies does not usually have equal intervention groups. As you can see, both studies start with adult population of 2,000, but with the non-randomized design, you end up having a much smaller intervention group. With randomized trials, we have to make sure that our intervention groups are equal with the non-intervention groups. Continuing in this hypothetical example of 2,000 subjects with myocardial infarctions, if we look at the case fatality percent within the non-randomized group, we may conclude that the intervention worked due to the lower number, when in fact we cannot compare the two groups since they're not equal. You can see that the intervention group that has mostly people without arrhythmia, thus not in such a high risk as people with arrhythmias. Now let's just talk about some very important randomized trial issues. Here are the most important issues that need to be considered when designing a randomized trial study: masking or blinding, unplanned crossovers, non-compliance, sample size, and generalizability of results. The last two we're going to cover in our next lecture. Masking or blinding involves several key components. First and foremost, we do not want our study subjects or participants to know in which group they belong, since it can bias their behavior. Just knowing that you will receive treatment may affect someone's behavior and reaction to the intervention. Patients can become hopeful and overly enthusiastic over a new treatment and elicit a positive response that is not the effect of the actual treatment. So how do we mask? We usually use a placebo or a sugar pill. the placebo looks exactly like the real treatment, but it will have no effects whatsoever on the outcome. Double blinding refers to when both the investigator and the subjects do not know if they received the treatment or not. It is wise to hide from the investigators who are involved with the patients as to who is getting the treatment and who is not as much as possible. Investigators may also be overly enthusiastic about something they worked so hard, and knowing who is getting the treatment and who is not may influence their behavior towards their subjects. You probably heard of the placebo effect. The placebo effect refers to when a patient thinks he or she is getting treated and starts reporting they feel better, although they haven't received any treatment whatsoever. Likewise, when the investigator knows who is getting the treatment, they may become biased and start recording the subject's responses a little bit differently. This is the formal definition of the placebo effect. Improvement in the condition of a patient that occurs in response to treatment but cannot be considered due to the specific treatment used. Depending the study, a placebo can be a pill identical to the treatment pill, or it can be a series of fake exams and tests. Crossover is very common with randomized trials, and it can be either planned or unplanned. With a planned crossover, the researcher has full control of the participants. The subjects are randomized to an either treatment or control group, and after a certain period of time on one therapy and after several measures have been taken, the patients are switched. Both groups are further observed and several measures are taken again. Changes that took place in group 1 while on the new treatment can be compared to changes to group 2 when they enter the new treatment. Thus, if the new treatment works, it should also show results in both groups. Essentially, each patient serves as their own control group since they are being switched from the treatment to a control group. This is a wonderful design, but of course it has a few weak points. Patients leaving treatment may have a carryover effect, meaning the effects of a new treatment they received may last longer, thus affect the readings from when he or she receives the treatment on the control group. Also, their behavior may change in case they did experience any benefits or suspected that they're being moved from a therapy to a placebo group. Nevertheless, this is a great design, but it cannot always be used. For example, if the treatment is surgery or a new therapy cures the disease, we cannot have the subject go backwards. Unplanned crossover is an important consideration and a lot of times cannot be avoided. We will see an example in the next 2 slides to better understand it. Essentially, subjects move to the other group for whatever reason, and this is not what the researcher designed. For ethical purposes, they cannot be denied treatment, for example, but since their participation on the group that they end up moving to was not planned, it has to be adjusted statistically. Thus, when the researcher runs the analysis, they keep the subjects in the group that they were originally assigned, regardless if they stayed or switched. This is called intent to treat analysis. In this example, we start with a defined eligible population. These are people who can receive a surgical treatment for their condition. The aim was to compare cardiac bypass surgery to medical treatment for coronary heart disease. Subjects can randomly assign to either treatment, in this case surgery, or medical treatment only. Meanwhile, after we randomly assigned participants, a few of the treatment groups refused to receive the treatment. Thus, we had to move them over to the medical treatment only group. Likewise, a few participants from the medical treatment group, their condition escalated and they required surgery. We cannot refuse to give it to them since that may endanger their lives. The issue is, how do we analyze the data in order to capture the unplanned crossover effect? We have the choice to analyze based on the original assignment, called the intent to treat analysis, as we said. And we will include it in the surgical group some patients who received only medical treatment, and in the medical group, we will only include patients who received patients. By doing so, we do not lose the benefits of randomization. That is what is shown on figure 7.7c. Of course, researchers may choose to move the people that crossing over in the group that end up being treated, like it is shown on the figure 7.7d, but they will lose the benefits of random assignment. There is no perfect solution for this issue, and current practice is to perform the primary analysis by intention to treat, thus to follow the original random assignment. Since this can be a serious issue, the unplanned crossover must be kept to a minimum. Non-compliance refers to when subjects are assigned to a certain group and they do not comply with the assigned treatment. Non-compliance can be either overt or covert, meaning subjects may openly share with the researcher that they disagree with the treatment and they will not comply, or they can fake it. They can pretend that they do what they're supposed to, but secretly do not adhere to the treatment or the guidelines given to them. So how do we improve non-compliance? You guessed it. We need to pay attention as to who participates in our study. Pilot studies are excellent for identifying non-compliers. Of course, the question is, why the people who comply choose to do so. That alone can introduce some bias in our study. Thus, when we try to generalize our findings, it won't apply to everyone.